Okay, well, the next 2 days we're going to cover these keywords. They're not very exciting. I suspect that reflects on the attendance. This will be posted on the wiki, the slides, after tomorrow. And I sent out to you a couple days ago the keywords that we're going to cover and the various resources. I've also had some PowerPoints from previous presentations that are relevant, I think, that are on wiki. So the first keyword had to do with the gas cylinders. I'm sure you're all familiar with this. On this slide I've shown the various gases, the state in which they're in, rather gas or liquid, and the color of the tanks, and the volume when they're full, and the pressure when they're full. What's notable is that when the agent is in a gaseous form, there's a direct relationship between the volume and the pressure. So for instance, with oxygen when it's full, it has a pressure of 2200 psi and a volume of 600. If the pressure is half of that, around 10 or 1100, then there's half that volume left, around 300. When it's a quarter, there's a quarter. Whereas when it's in a liquid, as long as there's any liquid in the tank, the pressure will maintain. And it's only when about 3/4 of the liquid is gone and all you have is gas that it becomes that the pressure relates to how much is in. So that would be true of nitrous and CO2. A second keyword was pipeline oxygen failure. And a key point here is rather the cylinders are turned off or on. As you note here, the main alarm is circled in the blue, and it notes when the pressure falls below around 35 to 40 psi. Now remember that the pipeline pressure is around 50 to 55 psi, and so when the pipeline fails, the pressure will go below this alarm setting, which is somewhere around 40 psi, and it will sound an alarm. However, if the tank is open, the tank supplies a pressure of around 45 psi's, and therefore if the wall oxygen pressure falls below 45, the tank will automatically start supplying gas to the system, and it will not sound this alarm. And therefore, you'll get no alarm even if you've lost the pipeline until the tank goes empty. And then the patient and you are in big trouble. So that's why it's very important that the oxygen tanks be closed at the start of the case. Now, I said there won't be an alarm, but the modern anesthesia machines also monitor the pipeline pressure. So if the pipeline pressure, as a separate monitor besides this oxygen alarm, there's a separate alarm that monitors the pipeline pressure. So in the modern machines, usually you'll get an alarm when the pipeline goes down. Is that clear? So as far as action, when you lose pipeline pressure, you should open up the cylinder on the anesthesia machine and check the pressure, and therefore calculate how much oxygen is left. Now, even if there was an adequate volume in the tank at the start of the case when you checked it, if there was some leak in the yoke, the tank could have lost some oxygen. In addition, if the tank had been left open, as I mentioned, anytime the pipeline pressure falls a little bit, and that occurs with high oxygen flow rates, sometimes from the ventilator. Remember, many of the ventilators are use the oxygen from the pipeline to drive the bellows. The pipeline pressure could periodically go down, and if the tank is open, it could periodically bleed into the system. Yes?
So if there's a pipeline failure, is it likely that, like here somewhere, that it would happen to all our ORs? Or?
Well, not necessarily. I mean, it could, but you could have a selective problem like a piece of lead or something that was in your particular room. So always check and see how much oxygen is left in the tank, and then think about how you're going to conserve this. And what you need to do is try to reduce the amount of oxygen you have until more tanks become available. One is to hand ventilate. Remember that many of the ventilators use oxygen to drive the bellows. Secondly, reduce the fresh gas flow. And thirdly, turn off the auxiliary oxygen supply. Remember that oxygen supply tube faucet should be turned off, but it might have accidentally been left on. Maybe you had it on when you were pre-oxygenating the patient with nasal oxygen or something and forgot to turn it off. And then, of course, you need to have extra oxygen tanks brought in, and finally notify the authorities about the problem. Now, a new keyword apparently was pipeline versus cylinder. We've mentioned that the pressures are different. The pipeline is about 50 to 55 psi. The cylinders, oxygen cylinders, when it's full, is 2,000 psi. But it may be less than that. And what happens when you have failure? I've just discussed what happens when you have pipeline failure. What happens when you have cylinder failure? Well, if the pipeline fails and the cylinders fail, of course you'll get the alarm, the low oxygen alarm on the machine. Secondly, the gauge on the oxygen cylinders may give you a clue as to what the oxygen is. And some machines actually monitor that pressure and warn you when that falls. However, remember that when the tank is turned off, the pressure that's being measured is right in here, which is trapped between the tank and the pressure regulator. And so it will stay at whatever it was when you first checked it. And then when you turn the tank off, it's not telling you what the pressure in the tank is. And if the tank has a leak, like where it's connected to the yoke, you could be misled as to how much pressure is in that tank. Any questions about that? All right, the next topic is a minor one. It's called vaporizers. The concept, of course, for all of the vaporizers is that volatile agents are liquid at room temperature. And at equilibrium, there is always some vapor sitting above the liquid. The amount of vapor that's sitting above the liquid is determined by the agent and the temperature. And the concentration is given by the vapor pressure of the agent divided by the total atmospheric pressure, barometric pressure times 100. So this shows, now the vapor pressure, as you know, varies with temperature. On this slide, I've shown you the vapor pressures of the agents that we use and a couple that we don't use anymore, but come up for discussion at times. You see at 20 degrees temperature, the vapor pressure above isoflurane about 240, above SIVO about 160, and above Desflurane about 660. And so the concentration in that liquid sitting above in the air sitting above the liquid is given by the vapor pressure divided by barometric pressure. So for isoflurane, the concentration of isoflurane sitting above the liquid is about 31%. For SIVO, about 21%, and for Desflurane, about 87%. So all of the vaporizers work by mixing a certain amount of gas that is going past the vapor, which has these concentrations in it, with the fresh gas flow to generate the percent that you want. So as you can see, if you want 2%, you'll take a small amount of this and add it to a large amount of fresh gas flow to generate 2%. With Desflurane, of course, you have to add very little of the gas that's sitting above the Desflurane in order to produce the concentration that you want. So there are several types of vaporizers. There's a conventional variable bypass that are used for isoflurane and sevoflurane. There's a Desflurane vaporizer, the Datex Omega cassette vaporizer, and finally the Maquet injector. The ones for SIVO and isoflurane are described on this slide. And basically, as I say, you have fresh gas flow coming in, and the concentration knob affects the resistance in this circuit and therefore determines how much gas comes down into the vaporizing chamber. The vaporizing chamber, as I mentioned, contains the concentration that we just described. For isoflurane, it's about 30%, for SIVO about 20%, and then it comes back out and unites with the fresh gas flow, and based on this concentration knob, it adjusts exactly how much of this liquid or how much of this concentrated vapor is added to produce the concentration you want. And on the next slide or so, I go into some more details of this. Now, the Desflurane is problematic because, as we mentioned, it has a very high vapor pressure, and you couldn't use these traditional vaporizers because it would vaporize so much that you'd have to have huge fresh gas flows, number one, and number two, because there's so much vaporization going on, it causes tremendous fall in temperature due to the heat used in vaporization. So they had to come up with a new type of vaporizer for Desflurane. And this is how it's described, but basically it has two separate chambers. One is the fresh gas flow, and the other is the vaporizer. And the vaporizer is heated to maintain a constant temperature. We mentioned because of so much vaporization, it would cool without the heater. So it's heated up to 39 degrees to produce this Desflurane vaporized vapor, which has a partial pressure of around 1,500 millimeters of mercury, almost 2 atmospheres of vapor. And then by a complicated system that we won't go into today, I don't think that's relative. Again, the same idea, it mixes this highly concentrated vapor with the fresh gas flow to generate the concentration that you want. And the various slides that are in this set go into more detail if you wish to know about it, and also the textbooks. Now, the Datex Omega vaporizer, which is used over at the Gill, is simply another way of accomplishing the same thing. In this case, and with all of them the same, basically, you have fresh gas flow, and it diverts some of the fresh gas flow over the agent, and then mixes the appropriate amount of the agent with the fresh gas flow to generate the concentration you want. Now, what's unique is there are separate cassettes for each vapor. So there's one for SIVO, one for isoflurane, and one for Desflurane. And the other feature of it is it's controlled by a computer. So when you plug the cassette in, it tells the machine what agent you have. And then by monitoring the temperature and the flow rates, it adjusts the valves so that it generates the concentration that you want. So it's the same idea of the other vaporizers, except rather than mechanical control or pressure control, it's controlled by the computer. So if you love computers, it's wonderful. If you're like me, I can't even run my own computer. It makes me a little nervous. But anyway, that's how it works. And finally, and again, I've gone into detail about how it works on the subsequent slides, and also is in the textbooks. The last one, which we don't use, I think it's popular in Europe. Maquet's a European company, and that's a fuel injector. I mean the injector, so-called. It's like a fuel injector, and basically what it does is it squirts the appropriate amount of the liquid into the circuit to produce the concentration you want. A very simple idea. The obvious limitation of this is non-rebreathing system, so it's wasteful, and especially with Desflurane. Now, another question that appeared in the past, and I don't know if it's appeared recently, is a vaporizer output. And this appeared in 2013, and I hope it hasn't reappeared, because it seems like a nonsensical question, but it said the volume of gas released per minute from a vaporizing chamber given vapor pressure and of the anesthetic and the temperature at sea level And I've gone through why, and I've talked to Dr. Schell about it, why we don't understand the question. Because since modern vaporizers are adjusted for temperature, the volume of gas released is really only dependent on the fresh gas flow, and none of those other features. I have provided a number of slides which go into calculating the output of vaporizers, which at your leisure you can look at. Basically, we said before, the concentration of agent is given by the vapor pressure divided by the barometric pressure, which we already, reviewed. So if the fresh gas flow is 5 liters a minute, and you want 1% isoflurane, then you divert about 165 cc's through the vapor chamber. This will exit at 31%, or about 51 cc's of isoflurane. And when you combine the two, you end up with 1% going to the patient. I have on this slide set a number of other comments about vaporizers which weren't in the keywords, but I think it's probably some things that you should know a little bit about, and they are relevant to our practice, and they may also appear in tests. One is some of the hazards associated with vaporizers, such as misfilling, putting the wrong agent in, tipping it, overfilling, underfilling, leaks. These are some of the factors that affect the output of vaporizers. Temperature, but we said all of them are now temperature compensated. Fresh gas flow actually doesn't affect the output of modern vaporizers in the normal operating range between 1/4 of a liter a minute to 10 liters a minute. Lower than 1/4 or higher than 10, it may affect the output a little bit. Interestingly, the carrier gas does have a little impact, especially nitrous, and at low flows, the Desflurane output from the Tech 6 vaporizer is reduced by about 20% when you're using nitrous, and that might be relevant if you use nitrous, i.e. When you are using nitrous, the vaporizer is not putting out as much as you dial in. And tilting can spill liquid up into the upper part of the vaporizer, and hence they'll get pure agent, which of course is bad. And of course, if you put the wrong agent into the vaporizer, that could screw it up. We have all sorts of safety features now, special indexed bottles, tops, caps, filling sites to try to keep us from screwing things up, but we still can do bad things. Here I've talked about what happens when you fill with the wrong agent. Remember, the vaporizer assumes that the agent you put in had the vapor pressure that it's designed for. So if you put an agent with a higher vapor pressure in a vaporizer designed for a lower, so if you put isoflurane into a sevoflurane vaporizer, it would generate more than you thought, and vice versa if you do the other way around. Finally, at least in the past, questions about altitude have been raised, and I discuss that here. with the Desflurane vaporizer, it delivers a constant fraction, a percent of the agent. So as you go to high altitude, if you set it on 6%, it will still be generating 6% Desflurane. But remember, the partial pressure at altitude for 6% will be lower than 6% at sea level, and therefore the partial pressure delivered will be less, even though the percent delivered is the same, and so the anesthetic efficiency will be reduced. On the other hand, the other vaporizers produce a constant partial pressure. So when you go to altitude, it will deliver the same partial pressure that it did at sea level, but the percent will be higher. But since the effect of anesthetics is based on partial pressure, the anesthetic effects will be the same at altitude as they were at sea level. Another question was ventilator disconnect. Remember that the ASA standards for basic monitoring says that when ventilation is controlled by mechanical ventilators, there shall be in continuous use a device that is capable of detecting disconnection. So how might it be detected? One is by monitoring tidal volume, another is by monitoring minute ventilation, and another is by monitoring peak airway pressure. The latter, of course, assumes that all other things being constant, if tidal volume goes down, then the peak airway pressure will go down. Some of you have noticed that many of our machines now, the ventilators, they automatically set these alarms. And if you change the tidal volume intentionally to cause the pressure to go up or the pressure to go down, you may get a false alarm because the pressure that it's selected to alarm at has changed. Probably, however, besides these machine monitors of disconnect, capnography is one of the best. And as long as you're watching it, and as long as you have alarm set on your capnography, this is probably our most sensitive monitor of disconnect. And almost daily, I see disconnect events occurring, and it's something that we need to be aware of at all times. This is from Miller's talking about methods of detecting leaks and disconnection. The next key word was Clark electrode. This is also called polarographic electrode, and is the basis for how the PO2 is measured in blood. It was invented by Leland Clark in 1953. And this is a photograph of Dr. Clark. It's quite relevant to us in this area. He was a biochemist who worked at Antioch College in Yellow Springs, Ohio, and also had an appointment in the Department of Pediatrics at the University of Cincinnati. He made some fundamental contributions to the practice of medicine and surgery. He discovered the use of silicone antifoam, which made bubble oxygenators possible, and in fact they developed a bubble oxygenator at Cincinnati Children's, one of the earliest heart-lung machines employed. He invented this electrode. He invented glucose electrode, and is sometimes referred to as the father of biosensors. He observed the oxygen carrying capacity of poor fluorocarbons, which led to the search for clinical artificial oxygen carriers. Quite a guy. And this is a picture of his original electrode in a review article by Dr. Severinghaus. And this is how it works. Basically, a platinum and a silver electrode inside a bath, and there's a semi-permeable membrane which separates it from the blood, and it then calculates the pH of the blood in this manner. Another key word was arterial blood gases measured versus calculated, and I've shown a little more than the question was asked. As I mentioned, the PO2 is measured by the Clark electrode. The pH is measured by what's called a Sance electrode, and the CO2 is measured by the Severinghaus electrode. Severinghaus was a professor of anesthesia at my alma mater, one of my teachers at UCSF, who invented this electrode, which made really blood gas analysis possible. Remember that bicarb, when reported from blood gases, is calculated. A lot of people make fun of the fact that it's calculated, but it's based on Henderson-Hasselbalch equation, which is a valid equation, and so there's nothing wrong with the fact that it's calculated. It's based only on the pH and the PCO2. Base excess, on the other hand, is estimated, and it makes a lot of assumptions. So it's not a precise measurement. Normally, when you send a blood gas, the oxygen saturation is calculated, and it's based on the PO2, pH, PCO2, and the hemoglobin, but it assumes a normal P50. And of course, we know that in patients, the P50 may not be normal. And therefore, the calculated saturation may not be correct. Now, remember that up on the arterial portion of the oxygen dissociation curve, the effect of changing the P50 doesn't make a lot of difference in the saturation. But as you move down to the venous level, then the change in P50 makes a dramatic difference in the calculated saturation. And so for arterial gases with PO2s above 60, probably the calculated saturation is not bad. But for venous gases, when the PO2 is down around 40, using calculated numbers can be very misleading. Having said that, and so it's best, if you want to know the true saturation, you have to ask for a saturation measured with a multi-wavelength oximeter. Well, it turns out that modern blood gas machines inside the machine, besides these other electrodes, have a multi-wavelength oximeter that actually measures saturation. So if you send a blood gas in our lab, when it comes back, you'll see where it says saturation, it says measured. And that is actually measured with a multi-wavelength monitor. Now, the other question was about temperature correction. And this is always confusing, or tends to be confusing to people. I hope I can make it less confusing. The first thing to know is that the blood gas measurements, when we send it to the laboratory, are performed at 37 degrees. if one wishes to know the partial pressure of the gases in the blood in the patient at their temperature, you have to use temperature-corrected gases. And these are given by nomograms, so-called, and provide you so-called temperature-corrected blood gases. So if you tell the laboratory what the temperature of the patient is, they will send you both the uncorrected and the temperature-corrected gases. Remember that the content of these gases in the blood is the same no matter what the temperature is. But the partial pressure changes with the temperature. So if the patient's temperature is lower, the partial pressure will be lower. Conversely, if the patient's temperature is lower than 37 degrees, which is when these measurements were taken, then the partial pressures of both oxygen and CO2 will be lower than what the lab reports. On the other hand, if the patient's temperature is higher than 37 degrees, the partial pressure of oxygen and CO2 in the patient will be higher than the partial pressure that was reported from the laboratory. Now, what really makes it confusing, I think, to everyone is what is the appropriate PCO2 and pH during induced hypothermia. And this is what makes it very complicated, because if the question is, what is the patient's blood gas at their temperature? Of course, you should use temperature-corrected gases to find out what's going on in the patient at their actual temperature. But the next question is, what do you want it to be when the patient is hypothermic? And unfortunately, there's no absolute right answer. There are basically two hypotheses or two strategies. One is called the pH stat, and this dictates that the temperature-corrected gases when someone is cold should be a PCO2 of 40 and a pH of 7.4 at their temperature. If that's the strategy you use, then the temperature, the uncorrected temperature gases measured at 37 would be hypercapnic. In other words, the PCO2 the lab would report would be higher than 40, and they would be acidemic. The pH would be less than 7.4. This is sort of how we ran hypothermic cardiopulmonary bypass until about 1983. We kept the gases what we called, quote, normal. Well, in '83, some people started to challenge this. They were at Stanford, actually, and they suggested that, in fact, for optimal cellular function during hypothermia, the patient should be somewhat alkalemic. The CO2 should be less than 40, and the pH should be higher than 7.4. How much lower or higher? And it just conveniently turned out that if the pH and the PCO2 in the temperature uncorrected gases were normal, i.e. at 37 degrees they measured 40 and 7.4, the temperature corrected gases for hypothermia of that patient would be appropriate. And so based on that, currently we tend to manage patients by keeping their blood gases measured at 37 degrees, quote, normal values, which would then result in, if you corrected it, to be hypocapnic and alkalemic. Questions? Have I totally confused you? I hope not, but if so, look it over again and question me further. Another key word was circle system. This is what all of our circuits are now. When I started out, we had a lot of other circuits that we had to memorize, but fortunately, those times are gone. But they do want you to know about the circle system. The circle system has several features. Number one, it has 3 valves: inspiratory valve, expiratory valve, and pop-off valve. It has a CO2 absorber. It has a reservoir bag. And what is unique is that it can provide none or total rebreathing of expired gases. Not CO2, but rebreathing of expired gases. And thus it can be totally open, semi-closed, or closed. So this is a diagram of the circuit. Again, the 3 valves: the inspiratory valve, expiratory valve, and pop-off valve. The CO2 absorber, the breathing bag, and the fresh gas inlet. And in general, the fresh gas inlet should be close to where the circle goes to the patient, and the pop-off valve and the CO2 absorber should be at the end of the circle before it goes back to the patient. And those are important principles in minimizing or maximizing the efficiency of the circle system. Now, in a circle system, rebreathing of CO2 is prevented by the CO2 absorber. So as long as the CO2 absorber is working, there should never be any rebreathing of CO2 with a circle system. However, the amount of rebreathing of the expired gases depends on the fresh gas flow. When the fresh gas flow equals the minute ventilation, there is virtually no rebreathing of expired gases. Conversely, as the fresh gas flow is reduced, there is more and more rebreathing of expired gases. And when you go to the closed system, in which you're only adding enough fresh gas flow to match the uptake, there's total rebreathing. Circle systems can be operated at high fresh gas flows, 5 liters a minute, at what is called low flow, and there's no official definition, but arbitrarily I've listed between 1/2 and 2 liters a minute as low flow. And a closed system, when, as I mentioned already, the fresh gas flow matches the uptake. If oxygen consumption is about 3.5 milliliters per kilo per minute, that would be about 250 cc's a minute. However, remember that in some circuits, the sampling line for measuring airway gases may take away some of this fresh gas flow. And so that's about 100 to 200 cc's a minute. So you may have to add a little more to your fresh gas flow to keep it closed. There are some circuits, and the Datex Omega ADU and the Draeger Apollo, both of these machines put the sampled gas back into the circuit, so you don't have to take into account that loss. The advantage of low flow is that you save heat, water, agent, and decrease pollution to the environment and save money. The disadvantage of low flows is that you can't rapidly change the gas and volatile agent concentrations. When you change the fresh gas flow, it may at least temporarily change tidal volume. And finally, it causes a discrepancy between what you're dialing in to go to the patient and what the patient is actually getting. Because remember, what the patient is actually getting is a combination of what's in the fresh gas flow that you're delivering and how much is in the expired gas which is being mixed with it. So the lower and lower the fresh gas flow, the less and less what's going to the patient matches what your settings are in your vaporizer. And I've explained this in more detail on this particular slide. So CO2 absorber we'll cover in a minute, I think, because the principles are pretty straightforward. There are, when I started it was easy. There was just one, the soda lime. Several others became available. Baralime you can forget about, but I guess that doesn't keep them from asking questions maybe. It's no longer sold. The new items are these various other concoctions, which we'll explain in a minute. This shows the concentration of agents in the various absorbers. This compares soda lime with Baralime. I'm not sure that it's too relevant anymore, except to the pH indicator. This is ethylene violet in these particular absorbers. The importance is that they can be inactivated by fluorescent light. And so you can't trust the fact that if it's still white, that it isn't exhausted because the color may have been dissipated by fluorescent light. And this is why it's important to change these periodically, regardless of what color they are. The new agents got rid of the toxic alkali, namely sodium hydroxide and potassium hydroxide. So the advantage of these newer absorbents is that they generate less compound A, they generate less carbon monoxide, and they generate less heat. And for that reason, they are recommended. However, as always, there are downsides, and one is that they're less efficient, and secondly, that they are that they are more expensive. So what is the problem with these? And the problems that have been described are the compound A, which is generated with sevoflurane, carbon monoxide, which is generated with Desflurane, and fire, which occurred with sevoflurane. These are described on this slide. With sevoflurane, dry baralime could produce fires, and there were notable case reports and beautiful pictures on the web showing fires developing, which is really scary. And this is why really baralime went away. The other issue is that the CO2 absorbents will cause production of compound A. Rather, in fact, whether compound A is a renal toxin or not in humans continues to be debated. It was particularly bad with baralime, and again, that's why it was gotten rid of. And for this reason, however, the FDA has this fresh gas flow requirement of at least 1 liter for 2 Mac hours, and then after that, you have to have 2 liters of per minute fresh gas flow, which is why Sevo is a little more was more expensive. However, its basic price has gone down so much that even with these higher flow requirements, is still cheaper than Desflurane. The other notable toxicity was the production of carbon monoxide. This is most prominent with Desflurane and very little with isoflurane and virtually none with sevoflurane. Again, baralime was a bad agent, and it was due to drying of the absorbent, and it was called Monday morning syndrome, and that was because if the oxygen was left on over the weekend, it would flow through the CO2 absorber and make it very dry, and when they turned on Desflurane, you could get significant amount of carbon monoxide. That has been eliminated by making sure oxygen is always turned off. So in the morning, especially every day, but especially on Monday, if you find that the oxygen is still on, you should request that the soda lime be replaced with new agent, which I guess I didn't mention, but at UK we use soda lime because it's cheap and we're cheap, but for this reason it's very important that the soda lime be changed regularly, and I think they have a good policy for this. And we'll stop for now, and I'll see you tomorrow morning.